We're about 15 minutes late, so we've got a lot to cover. Let's go. Welcome, everyone. And Ronnie. Ronnie's joined us. The next item on the agenda is approval of the minutes. Does everybody have a chance to review the minutes from our last meeting?
Move to approve.
Is there a second?
Second.
Any discussion? All in favor of the approving the minutes from October 24th, say aye.
Aye.
Opposed? Okay. Ad hoc committee on litigation. Brian, are you going to handle that, or Allison?
Well, I mean, that was, that's something that we addressed in closed sessions. I don't know how much we can really, say at this time, just that the committee on litigation, met prior to this in closed session to discuss, every matter.
Okay.
We can go into closed session and just do a quick kind of rundown of things.
You want to go through the meeting and do that at the end, so we've got other things, items to. Board governance, Jill, did we say 13 of the 23 counties have approved the nominations?
Waiting to hear back from Madison to approve the resolution. We're not sure whether they're slate.
Do you have a list of who those counties are that have approved the nominations? Can you read those out for us?
Alexander, Allegheny, Ash, Caldwell, Jackson, McDowell, Buncombe, Henderson, Mitchell, Polk, Rutherford, Transylvania, Yancey. That,
Okay, that's 13 of the 23.
correct.
And ones that have voted against,
Nobody, no one has yet.
The top.
We're talking about, okay, we're talking. And the resolution that was introduced by Macon County, I think everybody's approved it, have they not?
They
Yeah.
have. And what I think what other counties are waiting on to see if, when the secretary does sign the agreement, that's when the clock starts. So as you get, she's not signing it. We don't want to think it's going to happen sometime soon.
Anything else to add on those?
I had a little back and forth with Dave, and I asked about the status of the secretary agreeing, and he said it was on the agenda for their meeting this morning. And I haven't heard, I sent him another email just to see if I could get any status. I haven't heard anything back yet. So,
If she does sign, somebody let us know.
oh, I will, yeah, that's why I'm trying to watch real close. Also, I mean, since I got a laundry list, that was one of, I don't know, 4 or 5 things, and I also, just asked what in particular we might want to do about the secretary's appointment of our nomination, I guess, to her for Ed, and we just put like a little bio in about him around that too, to see if maybe we could get everything done at once. So we're waiting. Is that check cleared yet, Ed?
Of course, some of our, and my talks with David has been that while I go through the process, when we know there's no doubt, in just a few months, we're going to not only exceed the population, but blow it clean out of the water. So why jump through all the hoops and have all the hoopla between the counties when they ain't going to matter?
We'll talk about that, the timeline, that's what I wanted to talk about today.
We're going to get into regionalization.
Oh, why not?
Why not? Okay.
We're rolling right along here. What do we have in the packet here today? think via email, it may be hard to copy, everybody's seen this. I'm just giving it to everybody again. This is our one piece that explains what we're doing and why. And I would just, it'd be worth it to spend 2 or 3 minutes just to have people read through this. It's got the logos of the 3 on there. Take a look at that, and let's just start there and see if you have any questions about anything with that.
You got another pass here. I've got one here.
You just do one thing at a time. Take a look at that first. This. Any question on the words? We'll talk about some of the other pieces here.
The Western Regional Partnership consists now of 23 counties, is that correct?
Western Regional Partnership is R23 plus 8 of partners plus 4 of center point.
That includes all of it and everything.
That's the whole, that gets us to 35, right? Yeah. County-wise. People are very curious why we put this together to be something that we used. We did staff meetings, going back a couple weeks ago, 4 different locations, I guess, by the time we got done meeting with everybody, handed this out. And I think last month at the executive committee, I think we got this too. We just want to spend a little more time with it. And then Winston-Salem Journal, it got popped up there, probably because I sent it to the Hospital Association. They had made an inquiry about their involvement in our effort, and I sent them a copy of it. And of course, it took about 30 seconds for Richard Craver to get it. He wrote a little story about it. And that's going back a couple of weeks now. So, does this make sense? Does this sound like what you thought we were doing? Okay. To give you some idea of, I guess, what the work is we do, we had a meeting yesterday in Hickory. And the agenda, and I think it changed a little bit, but just it actually changed a fair amount. To give you an idea of what the agenda was like, I put that in there for you, so you can just see the meat of what we do. Again, this is, in many ways, the process is similar to what we did with Western, in that we had all these same business process areas, parts of our organization where we went through a process of, I think of it like this, discovery, how does everybody do everything, understanding that, and then trying to decide, is it, what's the best way? Is anybody doing it perfect? Do we look at doing a combination of how one's doing it or the other? Has somebody just perfected it? That whole range of possibilities. Because again, a big part of this is efficiency and standardization. And then the third part of that becomes deciding, well, okay, have we come to agreement on the best practice, the most efficient or effective way to do something? Again, these are the different areas. And if so, does that mean that all three of the organizations should be doing that? Or should one? And should the others contract with the other organization for that? And a good example of that, and we've got both extremes, where we have one area with credentialing, which is the process we go through that is to verify a practitioner's, I don't want to say credibility, but their license and their stature, put it that way, in common terms. It's like doing a reference on people. And it's a time-consuming and laborious kind of thing. Nobody really likes doing it. The decision that's been made by the group was that actually the Western Highlands, the legacy Western Highlands way of doing it is the best way to do it. And there's probably more efficiency with that, and as far as the bidding process, it makes the most sense to do it. The other two, Partners and Centerpoint, they don't want to do it. They'd be happy to contract with us to do it. And that was decided yesterday. So on one end of the spectrum, and again, this is kind of the low-hanging fruit. That's a pretty, relatively easy one. It's almost like there's three people standing there. They asked for a volunteer, 2 step back. One was left, and it was us. It's probably closer to it. It's not a real popular thing. So we'll work out some kind of contract and pricing so that we would begin to do that. And I think the timeline is probably off into the spring because it involves quite a bit of effort to lift that up. Versus other parts that are, just much, much, much more complicated that you can barely even look at how we do things. It's just scratching the surface. And everything in between. And that's, the meat of the work is that right there. The challenge, of course, with this is the pace. What are we planning for when? I know there's been a lot of discussion about this, just as Ronnie said, every time we've been on a governance thing, been, people linking the changes around what seems to be eventual merger, and we're very careful about, the words with all of this. I can tell you the sensitivity is at 11. It's not 10, it's 11, okay, on the scale with all of this stuff. The difference here, with all due respect to Western, there was a contract termination. With this, nobody's had their contract terminated, everybody's doing great. We're doing this because it's in more or less agreement with the state that if we get down to 4, and we've showed you the map, and you can look for yourself, we can go from 10, and I think we're getting pretty close to 9 now. We just assume that Mecklenburg is going to go to Cardinal, which it's inevitable, I would say. That's not news, just in the process getting there. We get down to 9. How do you get from 9 to 4? That would bear well for we do and how we do it, okay? And by that, I mean the 1915 DC waiver, the way the state has approached the management, public management of care, that would fare well for us in the future, okay? And what does that mean? Well, you know, for the first time, I think this was last week, you know, the secretary and the governor had, I think 2 weeks in a row, there was a, I don't know what they called it exactly, it wasn't a press conference because no press was invited, there was a meeting at the governor's mansion, and there were, you know, people invited, and they talked about Medicaid reform and a lot of big initiatives with the state, and then following that, they had, you know, more of a regular press conference, and there were very specific comments made, really for the first time, about the great value of the MCOs and regionalization, and really saying out loud that that was the path for the future, if you will. I'm paraphrasing, but I think this is a fair, you know, language to use, that would allow the secretary to, I'll say, include us in the Medicaid reform plan that she has due to the state March 17th, okay? Well, what does that mean exactly? Well, I don't know what that means exactly, but that's a lot better than, you know, somebody coming in the room and having a private conversation with us, which is not what we were working from before. And I think I've seen a couple of things where Dave Richard has been out basically saying the very same thing. And we could, you know, find those. I don't know who gets those. They're pumping them out about every week now from DHHS. They're little sound bites and infographics. We should be sure, Jill, that I guess whenever we get those, we'll be mindful to send them out. They certainly have changed their market. It's interesting to watch all of this. So, well, what does all of this mean? What's the timeline? What are we planning against? Because, you know, you look at these items here, and we have all of these groups that are accomplishing things. Well, what should the pace be? And what kind of things do you take on? Well, you know, if you use the example of Western, you know, we had a program we were going to get to on October 1st. We had a management agreement and all the kind of pieces that, you know, organizations would use to define the pace and the deliverables that need to be accomplished. It's just a logical way of going about things. This does not have that because we're not planning against a plan, if you will, from the state. What we know is that March 17th, the secretary has to come out with her plan, and that will be whatever that will be. And then what happens next? Well, the General Assembly meets, when do they start? By the first part of May. So May, June, and some part of July, you know, they're going to do whatever they're going to do with it. And I invite any of you to offer your thoughts about how the sausage gets made here on this.
One of the things the county is worried about, it's already been talked about, Michael, is if you don't know, the county went into an agreement 4 years ago about a Medicaid swap with the counties. And we'll do a high cent sales tax. For instance, Macon County is about $800,000 it saves us. It's a huge amount to every county. You can get those numbers. And now the talk has been made, but maybe that was too sweet of a deal. So part of the money that you're looking at, I'm afraid that's what they're going to look at it, is to come back on the Medicaid swap that we agreed to with the state. It's going to cost all of the counties, that's 1 cent where ours is now, that's a 1 cent tax increase in our county. And in Michael's County and in Judy's County and every county, it's a big deal. This was Representative Lewis that made those comments. Don't know what part he plays, but we're certainly keeping an eye on that because that is huge. That is a huge deal. They back up on that and not give back the high cent sales tax.
A lot of pushing and shoving.
Oh boy, that's a huge It was a good deal for us. I mean, it really for all the county,
So what you're saying is give that back to counties?
but we don't know. I mean, that was, I think we feel that discussed.
Do they keep the sales tax too?
I don't know. But I'm sure that's one, I just think, from all the word I was down there, week before last, that's the word. It's going to be on the table. That's all I've heard.
In other words, counties have no say-so.
That you're not so far. But we have an agreement with this, and I think most counties, regardless of the political makeup, they will come knocking on the door on deal. We'll just have to wait and see, and they may just float it up there to see what kind of resistance they are to it. But that's, I think you're gonna hear more and more discussion about that. That's huge.
So, the secretary will, actually, there's another piece in here I should have added. There was, and I think this was in the budget bill, you know, that they decided that the governor would appoint a Medicaid reform panel or something. It's a 5-member panel. And there's 2, I don't know, I could look it up. I guess people probably, have you seen that in the news? There's a couple of retired hospital CEOs. There's a provider, Peggy Terhune from Monarch. I guess Bob Atlas is ex officio, my term anyway. He's a guy that they have brought in who is a pretty well-known managed care expert nationally to be kind of the brains of the operation around designing this for North Carolina. Let's see, Nelson Dollar and Pink, I think, is the other 5. So that's the group, and I think they begin meeting here pretty soon, right after the first of the year. You know, what is their job exactly? You know, they're going to start to float things out, and I don't know what official capacity they have, but that'll be really the first opportunity that the state has to start showing some cards. And then, of course, it comes to the General Assembly. So let's just walk through all of this. It's very important, you know, in terms of, well, if you want to think about this in relationship to governance and how the board would change, the pace of work we do in the Western region, you know, the monumental transformation, you know, we'd be challenged with. The General Assembly, there'll be a lot of pressure for something to get done. Now, you know, again, your guess is as good as mine. They could just stalemate the whole thing. They could decide, no, this isn't good enough, we don't like it, we're gonna just study it some more. Or they're gonna go ahead with it. And I think there's a huge amount of momentum, you know, around going ahead with something. Now, what would something be? It would probably involve the state submitting to CMS another request for a waiver, do some things differently. And it's likely that that would be a different type of waiver than the 1915 DC we have now. It would be an 1115 waiver. Many other states have done this, okay? So how long would it take for the state to put that waiver together? Well, if they use consultants that have done this from other states, and the waiver for North Carolina looks a lot like the waiver for some other state, it could happen in a couple of months. If they want to get really fussy and have a lot of conditions associated with it, it could take a lot longer. Okay, so now we're into kind of a range of everything from a couple of months to, it could take a year. Again, depending on the pressure and the approach. So it gets submitted to CMS, and the burden of proof for, and again, let's imagine that this is an 1115 waiver. And the 1115 waiver is called research and demonstration. And it's very different than the 1915 DC.
Yeah.
The 1915 DC, what we do now, there's just a ton of boilerplate with that. Those are relatively straightforward, relatively simple to put together. You know, people understand them. It's well defined. The rules around how they're done and how they're evaluated, it's all just regular business. Research and demonstration waivers are different. It's saying, you know, it's basically a state saying, we want to do something different, here's what it is we want to do. So of course, the standard of review and how could we call it? Accountability and how that would be demonstrated, and any kinds of safeguards or contractual issues. It's just a much bigger laundry list with something like that, where literally you're inventing, you're coming up with an idea. And you have to sell it to CMS, and of course it has to be approved. Well, how long does that process take? Well, again, if the waiver from North Carolina is a lot like waivers from other states, it doesn't have to take a huge amount of time. If it's something, off the chain, then you're talking about a long period of time. So they get that in place, it comes back and it gets approved. That would then allow the state to go out and do the RFP process, which the Secretary talked about way back in the spring, and again, the original idea there was you would have these 3 or 4 comprehensive care entities in the state that would be responsible for all Medicaid care. If you put that timeline together, you can get a timeline that goes to probably July of 2015 to July of 2016. As the point where, if you're thinking about us, what does Smokey have to do? Where we would have to be a different type of organization. We would have to have, let's say, a merger accomplished by that date to play in that new sandbox. So that's the timeline. That's as much as I can tell you about the timeline today. As we go along with all of this, all of those things will become more clear. Again, what are the variables? What's the Secretary going to propose? What's the General Assembly going to do with it? If we get something, how like or similar will it be to other states, which will make the whole process go quicker? Will the state use consultants who know what they're doing and have done this with other states, et cetera, et cetera? Will it be easy for CMS to review and approve? That's what I can tell you.
Yeah.
How much of that type of waiver is about process and how much is about coverage? In other words, how much is about can a Medicaid client go to the doctor in ER versus the state?
Well, the coverage, it'll be, yeah. Well, the Medicaid plan, the things that Medicaid pays for, there would not be, I don't think we're talking about big changes in what Medicaid would pay for, okay? It would be the type of managed care that would occur around the management of those services. That's how I put it. That's really what we're talking about. And again, you think about what we do. We have a special population. We have, depending on what words you want to use, the seriously and persistently mentally ill. We have individuals with developmental disabilities and intellectual and developmental disabilities, which, by and large, that's a lifetime situation for folks. With some degree of change, but again, a long-term thing, there's like chronic mental illness, substance abuse being, a little different, where, it's a chronic condition, maybe a lifelong condition, but there's remission or recovery. But you're talking about, people with very significant, disabilities. And that's our,
1915 was so population driven, numbers driven. Is the other waiver the same thing? Is it?
No. That is often used to expand coverage. It can be used to expand coverage for care. Right? Other states have, it's a way for more people to have care, more the direction you're talking about, Mike. I don't think that's what North Carolina is going to do. The focus for North Carolina is around how do we get everything that Medicaid pays for in health care including behavioral health care and IDD. How do we get our arms around that with a managed care plan?
Because I was actually thinking the other direction, because I see,
Restricting?
I see them restricting more than having to.
You know, they can, you know, who knows, but I don't think the impetus is in that direction. I think it's more about the totality of Medicaid and coming up with a containment plan for it.
Yeah.
Long-term care, dental, you know, the whole 9 yards. You know, so now you have to start thinking about, well, so how would the secretary include us? What would constitute being included mean exactly, given what we do? And there's different, and you know, that's probably a whole different conversation that we need to start having maybe next month, because there are some ideas about that that I think are, you know, reasonable guesses that you could make. But again, would result in significant change from how we do business now. So we're talking about gigantic change there. We're talking about gigantic change in terms of the scale of,
Yeah.
you know, the amalgam of 3 area programs, 3 MCO regions, 35 counties in the state, all within the next, well, let's say 2 years, plus or minus. Sound like fun? We're the implementers of public policy, right? Just like counties are. That's what I can tell you about the timeline. That has to fit into the work we're doing as part of this regional plan. As sketchy as that is, that's at least the framework that we have. You know, the other piece of paper I put in there around this is, and I do this a little bit tongue in cheek, but I don't mean it in a way to make fun. The consultants and the counselor group are working with us on this, and of course, you know, at some point people say, well, you know, we need to come up with like a fact sheet where we can say, okay, Centerpoint, here's what you guys look like. Partners, here's what you look, Smoky, here's what you look like. So we came up with, we called it a comparison chart. And there's so much sensitivity around comparing one to the other that the name got changed. Now it's called a information and data point chart. And again, this is just draft, and to give you some idea of parameters, you know, how we look at ourselves.
I had a comment about this, but before we read that other, I would guess, to use your terminology, if we're going to play in that sandbox, we need to not only have merged by that point, we need to be showing success at it. You know, with other countries can say, okay, our merger's live today. Sure. You know, you're starting with, I think that's really.
Well, you can make, I mean, it's like, again, if you think about the experience with Western, we started doing a lot of things together in the same way, if you will, before we were officially merged. But you're not wrong, Michael. I mean, it's not like there's a magic button so much that gets flipped, although from a contractual standpoint, you know, that's kind of the where you're then able to do that because you are one organization. Operationally, a lot of things. So,
In terms of this number, the question I was going to ask is on the psychiatric admissions claims received both Medicaid and state and partners. Is that is this typical of them, or is this just an anomaly? It seems like those are very high. I wonder about their,
good
they're
question.
going to have a financial problem later on? 'Cause
Well-
that seems like a very high.
I think, you know, we gotta be a little careful. You're making a good point. You know, we're looking at 1 month of data. Is this supposed to be February 1st? What are the dates here?
That's the good last day.
Oh.
This is the August monthly report.
Okay, yeah, this is the August, and September actually just came out yesterday. I don't know, you know, Michael, I think, you know, we probably gotta be pretty careful about, you know, reading in too much to things, but, you know, you just see the sizes of things, you know, it's very, very different. Number of counties, these are just general parameters actually that are part of another report, a few things added on that's sent out every month. So, I know there's, let's see, Judy, Ed, Rick. The three of you folks are part of our contingency at Pinehurst. They're meeting with, board members from Partners and Centerpoint. They have kind of a icebreaker. So, I'm gonna break some ice to jump through the ice. What more can we talk about here? I mean, you know, we're gonna need to talk about this needs to be an every month thing now.
Do you know how many employees about Partners has?
Yeah, about 380 ballpark. Ours are higher. Part of that is related to our transition. You know, that's going to settle down. I don't, you know, staff here is not a staff meeting. You know, this whole thing is part of an adjustment period really for us still. I mean, that number's going to come down.
What, their catchment area is so much easier than what we,
Easy for us to say, Ronnie.
but it is. I mean, just by distance. You go from Cherokee to Allegheny County 2 times a day and see what. No, you
Yeah, I
can't
mean,
do
there's,
it.
you know, you're talking about 4 counties with an urban area, you know, I guess what.
Concentrated population.
400,000 people in Winston-Salem area. But by the same token, you know, their number of eligibles, you know, Centerpoint's only 7,000 compared to more than double that. Very big differences. I would say staying away from value, you know, you have very different organizations. And different leadership and approaches to things. So.
I agree as an objective data point, square miles covered is an issue when you're talking about direct service delivery. I think that's more what Commissioner Bill's getting at, is the size of it, versus making these structures.
I think in there somewhere, do we have a number of counties? Yeah, we do.
Yeah.
But even
Yes,
that
in
doesn't
square
really
miles.
get at the
You're
mileage.
right, you're right.
The-
I'll pass that along. We'll win on that one, that's for
We're
sure.
winning on that.
Big. Yeah, I mean, we're the,
But I
Biggest
bet that drives
mistake.
some of the staffing numbers because of the commitment to have a presence
Mhm.
in county.
it's, having a bigger territory makes it harder. I'm careful where and when I say that, but that is true. And not everybody would probably believe that, but I feel pretty confident in saying that. Okay.
We had a conversation with their CEO, right? If you had a conversation with their CEO.
Yeah, we've met. I mean, we had a big powwow yesterday all day in Hickory. We have CEO to CEO meetings. We have meetings that involve a steering committee of probably, you know, we each have about 4, you know, senior staff that we bring, and then we have these work groups. Excuse me. So, yes.
You have got a reaction to that, you want to speak to that or maybe not? Oh, we have a eye in the sky. Move on.
Simple question. It appears that one of the reporters has speculated on the fact that it would be a new LME, so to speak.
New entity.
Yeah, new entity.
Yeah.
And would you like to speak to that somewhat?
Sure.
You know, the approach is that there is no dominant partner in this, that we all go into it open to creating a new organization that is the best of the three, an amalgam of the three that has the best components of the three. So in terms of, that's why these, you know, words like merger, and again, and this is such a double-edged sword because sometimes we talk about this in relationship to the effort with Western, which causes tremendous concern with our partners because to them that means we're quote unquote, you know, taking over.
Taking over, right.
And, you know, we didn't, I never felt like.
Well, that's the feeling that I get
Well,
from the council level right there. You
Well,
kind of get that.
and we didn't take over Western, I mean, that wasn't the process we used. And but it's going to be very important for you folks to just, in your own terms, explain, you know, how we did what we did. Okay, but I, you know, I've almost stopped trying to explain that it's a process. It's a process, and, you know, much like this process where we're taking the best of both and putting it all together. Of course, the difference with Western is, you know, there wasn't going to be a Western at the end of the day, and we all knew that. Nobody wants to think that way about themselves in relationship to this effort. Okay?
But the reality of what happened to Western is probably part of what brings some of these other people to the table. The reality, you're going to figure it out on your own, and the state's going to figure it out for you.
Yeah, you know.
I mean, that's just the truth.
They had, the LOC meeting was this Tuesday, and they talked about this, I don't know, it might have been Tom Chillis or somebody, you know, the voluntary effort of regionalization. It's like, yeah, we're voluntarily going to walk off the plane, you know, I mean, define voluntary. And I guess they were using the example of Mecklenburg or something, but it's the same with this. Well, is it voluntary? Now, there's a whole rest of the state that's wrestling with this, okay? And as a matter of fact, we're supposed to have our straw vote tomorrow at the council meeting about, is everybody committed to this regionalization plan? Because really, I guess, you know, the secretary speaking at Congress, and the idea is that, you know, she'd be able to go and have a map and say, yep, you know, here's the, you know, one of her big terms now is the coalition of the willing. Here's the coalition of the willing. Here's the map. This is what the regions are going to look like. And every one of these NCOs has said they're committed to that. That's really, tomorrow is pretty much the gut check on that. Now, what does that mean? Okay, that, you know, that means is that you're going to cast your lots. I guess. That's the easy part of the conversation. Just think if this, you guys, these county meetings, think about your county, there are gonna be 4 counties in North Carolina. How'd you like to tackle that?
I'll be in charge.
And you could have 96 others saying the same thing. You get the idea?
Actually, I would say that all 100 of the county members out there would probably turn and run from that.
Well, that's kind of what we're doing.
Yeah, it is.
Okay. Any more?
I started to say, I found it interesting that the secretary is also asked to be at our council board meeting
They find
You
that
can
interesting.
just Tiger's also there, so she can be there.
Who else the one had wrapped around? Who else?
Judy, myself, Rick, who, Dorothy Crawford, yeah.
Yeah, Dorothy, yeah, I'm sorry, Dorothy's gonna be part of the, Pinehurst group too, right?
Right.
Yeah. So 1, 2, 3, so 4 CEOs. Okay. Well, next topic here, we keep rolling, how's our time anyway?
You go.
Okay. I feel like it's an important part of my job to make people aware of things like performance. How are we doing kind of thing, and we talk about that in different ways. The state has different publications that they have that are regularly done. And to be honest with you, we don't spend really much of any time going over this stuff. Sometimes it's part of the consensus agenda, but I wanted to have Julie spend some time kind of taking you through what are the kind of standard reports that are out there around, let's say, performance. How are we doing and what do people think about it, I guess, in different categories. And ask how you would like to, I guess I'll ask you, are we paying enough attention to this as a board? I'll leave you with that thought. How important is that for a board to be involved with having some degree of understanding around it? So, anyway, Julie, you want to do the tour here?
Thank you. My name is Julie Sinclair, and I'm the Senior Director of Quality and Integrity Operations. So this falls under my purview. I would like to walk you through the information from the most current to the most historical. So we're going to start with the papers that look like this. They're graphed, and on the top, the first one says LME MCO monthly monitoring report, Medicaid and state combined is the first one. And if you want to put it next to this packet that says consolidation of SMC and WHN, what you have is the report that we submit to the state every month, and then a few of the things we've done in visual representation so that you can see it in a different way.
What's the second thing you have there?
This consolidation of SMC and WHN, it's a thicker packet. So in the graph, you have Smoky Mountain Center's reporting from January through October. And October does include the consolidated data. So there is a bit of a jump. So if you look at the first item, the total number of calls that we receive, and you open your companion document with the graph, you will see the combined totals, and you would think that it would average out to be our consolidated number for October.
Some of these,
On this graph,
excuse me, some of these, for example, are the same metrics that are part of that other
the average,
comparison chart that's now an information data point chart.
which they'll see in a second, the comparison, I have that too.
You don't include the calls going directly to the provider.
No, this is calls coming into our call center.
Like people going to the ER most time, they contact the provider.
It's a mix. Yes, but it does not include those calls, you're correct. And it does not include calls through the regular business number that somebody might be calling Brian or Christina. It doesn't. It's the call center calls, people requesting services
And
or
we get that
asking for
information from the provider.
I don't have that.
We didn't have that somewhere, right?
Yeah, I don't, we could ask, I mean, we got about 600 providers.
Yeah.
Interesting to see. That's
We,
the true number.
It may very well be that on Jenny's report for the crisis data, you would know how many crisis calls come into the mobile crisis management providers.
Actually, at the board this evening, I know you got to take off, right, Ryan?
I gotta be in Bryson City at 6:30.
Well, we're going to have RHA's going to come in and do, actually, we're going to combine the Vantage Point, talk about a consumer family, they had experience with using that service, and also I asked them to do kind of an update because that was really pretty significant change we made in association with the Western Highland counties. So they may be able, they'll be able to talk about that to a certain degree, at least from their perspective, because they do get a fair number of those calls go directly to them.
So, no, that's okay. If you look at this first section, call center, on our reporting document, you'll see in the very first column, there's the second column actually, it says standard. A lot of those cells are grayed out. If there is a standard or a performance expectation, it's listed in that column. So you'll see in the call center, we have the expectation that fewer than 5% of our calls will be abandoned. That means we'll answer them before somebody gets tired of waiting for the rings and hangs up. And that we have the expectation that we will answer 95% of the calls within 30 seconds of that first ring. So we have those,
Julie, is that measured electronically, or is that? like
yes, our phone
separate?
system measures that automatically, yes. So if we turn to the second bar graph, I want to point out something to you. It's the percent of calls abandoned, 2013. You'll see that October is higher. You'll see that both Western Highlands, which is the orange bar, and Smoky, which is the dark blue bar, are achieving a pretty good performance until October when we combined. We still met the measure, but what happened here, and this is part of how we look at the data, we look at the anomalies and then we look at an explanation for it. What happened here is we had a lot of new employees answering calls, therefore the calls were taking longer. There was a training going on and a learning curve, and so more calls were abandoned because people were having to wait more rings to get answered and they just hang up. The abandoned calls are the ones that hang up before they're answered. If I pick up, if Judy's calling me and I pick up and she figures out she had the wrong number and she hangs up, that's not an abandoned call. So it's any call that's not answered before it's somebody live answers the phone.
Although theoretically, you had someone who was frustrated and kept, hanging up and calling right back.
They could skew the numbers.
Skew the numbers, right?
They could. Okay, so one thing I want to note as we go through this October data, we met every performance measure, even though we were consolidated, which I think is pretty impressive. I don't want to spend too much time on things that you may or may not want to know about, so if we turn to the next page and look at primarily the items that have standards, then that might be the most useful. Although you can see the number of people we serve and that these are unduplicated counts up here for people who enter services. So if I have a person with intellectual or developmental disabilities and I also have a mental health or substance abuse diagnosis, I am counted once in each category. So it's unduplicated within the category itself. And then when you get to the bottom where it says unduplicated numbers, that's a total unduplicated count. We have those in graphical representation too. You might notice on, do you get the page numbers over there? It says persons served DMA. It looks like we serve fewer people, but this number is based on paid claims. And there's a 90-day claim period during which the providers have to submit their claims. And many of the former Western Highlands providers who were not also smoking providers were a little bit slow to start using Alpha. So next month, we would expect that the person served number to be more equal to the previous months. But it's based on claims data these persons served. One of the expectations, if you look under community psychiatric hospitalization, that last line, is that anybody who is readmitted to the hospital, and a readmit is considered anyone entering the hospital within 30 days of being discharged from a previous hospitalization. Anyone who's at, the expectation is that 85% of those will be assigned to a care coordinator. We assign 100%. And we've been pretty consistent with that if you look historically, 100%. We're good on our authorization timelines. We process 99.9% of our authorizations within 14 days. The expectation is 95%. There is a process, if somebody has an emergent need for a service, they can request an expedited authorization, and that's required to occur within 3 days. We also need that at 100%. Do you have any questions about this Medicaid data? Anything you see here?
You know, maybe the first time through is just getting your brains kind of wrapped around what are the criteria that are established as important for us. You know, what are the things that, for example, in our contract are issues around performance, or something's going to get measured, and there's some criteria for whether you're doing it good enough or not.
I think that, yes, Brian, this is probably best viewed as an orientation, and then if you want to go home and look at it and tell us what you want us to report out monthly or quarterly, so that you know exactly what we're doing and how well we're doing. We'd appreciate that input.
See, it's numbers, but, you know, Jerry, for your, perspective, and you're always keeping us on our toes around about the people. This relates a lot to people and what kind of service, what's happening to the people we're serving. Everything from, customer service, how fast do we answer the phone? How well are people cared for in the community through service? How often do they have to get hospitalized? What do they then have to get re-hospitalized? Something that we wouldn't want, So it's numbers, but the numbers are very important around clients and families.
And speaking of clients and families, the next page of Medicaid-only data, you'll see you have the complaints and grievances. And I found it very interesting that if you look in the September column, there were 21 grievances filed at Smoky Mountain Center. That was the 15 counties. And in October, there were 22, and that's the 23 counties. You would think that during the time of transition that your grievances would spike. So I think that says a lot about the staff at Smoky Mountain Center, that the grievances did not spike. And we handled the grievances, 91% of the grievances within 30 days of the initial phone call.
Another good customer service piece. So you got a problem with us. Okay, you don't like the way something turned out for you. Very specific process we follow or how do you get to complain about that, just to use common terms?
Well, you can include most people talk to the provider. If they have a problem, they go to the provider who gives the service.
About, a lot of times they do, and if they don't get it
This don't
resolved,
reflect that.
if they don't get it resolved at the provider, then they come to us. So if you look down, it says number of consumer complaints against the provider. So 14 of the 22 were probably because, Ronnie, they complained to their provider. The provider did not satisfactorily resolve their issue, and so they called
Did they
somebody,
call you?
asked for intervention, yes.
Or they could call us first. I mean, this has to be
Sometimes
an
they
open
do.
door for people, that's the point of it. Now, at what point they get there, what process they may or may not have been through with the provider, that's up to them, but we make sure this is an open door for people.
The, are the pages legal size? There are 2 legal size pages of graph, and that represents our state funded services. So whereas we've just been looking at the Medicaid services, now you have similar numbers for our state funded services. And we have some similar performance. And I really do think it's really commendable of the Smoky Mountain Center staff that we met all our performance measures in October despite the transition. I don't know, there are no highlights different from the Medicaid data. So if we were to say fall below expected measures though in the authorization, we would go to our clinical operations department and we would point out the measures and ask them to investigate what happened so that we could either do an internal corrective action plan or a quality improvement project so that we can provide the best services and, of course, reflect it in our performance
I
measures.
mean, that's the other part of it. Okay, so, you know, are we always gonna do everything perfect? No, we're not. So when we find that, we have a process for making sure we address it. We have to come up with a plan for how to make it better, and then we have to monitor the plan around how we're doing to make it better. So it's not a, you know, there's nothing that just kind of flaps around, I guess, is what I would hope would be your takeaway here. This is a complicated business. You know, you're getting a view of, you know, kind of more a little down in the depths of all that's going on and how much of it has to be carefully looked at. And what our responsibility is for how well we have to do that.
So the state takes this report and they look at it, and if you pull out your another packet, it's called MCO comparison. It has blue stripes on the top and the bottom, thinner stripes. So what the state does is they take the numbers that all of the LME MCOs provide for them, and they put it together. Brian mentioned to you that we got our September data just today. This particular packet is the August data. We did it in a graph form that looks just like this report that we submit. However, this presentation for you is in a visual form. So as you look through the slides here, Smoky is in green. The other LME MCOs are in blue. You would look on this page 1, you have the call center. That red line across these slides is the performance expectation. So on the top 2 slides, we want to be below that red line, but in this bottom measure, we want to be above it. And you will see in the, we have both a visual representation and the data table at the bottom that shows the numbers. If you like numbers better than bars, you can see, and it identifies the standard. Highlighted in yellow in one of the numbers shows that the LME MCO did not make the standard for that month. So if you just scan through this, you'll see another way of looking at our numbers compared to the other LME MCOs. On page 4, you'll see that there is a standard for this measure, and all LME MCOs meet or exceed this standard of authorizations processed within the 14-day time frame. One important one is slide 5 for providers, claims processed within 30 days. We have a prompt pay guideline, which is 30 days. So this is something that you can look at and see. We will present this to you every month. If that's something you want to look at. Unfortunately, it's a bit more historical because it takes time for the state to consolidate the data and send it out to us. But we should have September's for the next board meeting. Do you have any questions about this presentation? I think the last thing I brought for you to look at is called the Perception of Care Surveys. And it's two different graphs. One is a big, thick blue line across the top. In January, DMH DDSAS sent out to us perception of care surveys, and we in turn had to distribute those to providers. And the providers turned these surveys back in. They selected the consumers at their agency to fill these out. A certain number had to be adults, a certain number actual adolescents filled out, and then some were legally responsible persons. And these were the responses for the providers in our 2 LME MCO areas, because in January there were 2 LME MCOs, so you have the data presented side by side. I know that one of the interesting things, this is where we look at, an example of how we look at data. The first question on this page with the pie charts said, did you receive a consumer handbook within 14 days of starting services? Well, you are required to have access to a consumer handbook within 14 days of starting services, and what the contractual requirement is that we do send a letter to everyone within 14 days of starting services, and we put a link to the handbook on our website. But if they want a handbook in that letter, we describe how they can contact us for a handbook. And if one of the staff was keen enough to notice that, people may be saying no because they get a letter, even though we meet the requirement by giving them access to a handbook, they don't actually physically get a handbook. And this might be a place where with technology, we would need to change the way we phrase the question. Regardless, we had pretty positive responses.
What's your response rate, Chief? How do you know your response rate?
It's not like a typical survey. The providers were just required to give us a certain number, and they get their consumers to fill out that number. Let's say Ronnie provider was required to give us 38, he got 38. So it's not a survey that we send to 100 people and see how many we get back. I think we did pretty well. Just for your information on the bar charts where they're like this, it's the non-negative responses, so it does include neutral and positive responses. The persons surveyed were allowed to, they had a 5-point scale, strongly agree, neutral, disagree, and strongly disagree, and these are the neutral and agree and strongly agree responses. So this is just some of the data that we look at every month, and the system performance team takes to the different departments and the different cross-functional teams to review this and look at it and interpret it and evaluate our performance and improve our performance.
Yeah.
The at-a-glance that you get in your packet every month is sort of a summary of what you could have in more detail. If, as a board, you want something in more detail, and you see one of these reports and you want us to do some analysis on it, or a number that you want us to do analysis on, we'd be more than glad to do that for you. I don't know if there's, Brian, did you want me to say anything else about any of it? It is a lot of information. It's a little bit overwhelming. I look at it fairly frequently, so it's like second nature, so I know a lot to take in.
To some parts of this, and which documents exactly are on the consent agenda?
Actually, none of these are on the consent agenda this month because they were all on the consent agenda last month.
Right,
But
but typically.
Typically, the at-a-glance is
Okay.
on the consent agenda, and the at-a-glance is our way of summarizing what we think people are interested in. And that's a good point, Brian. Now that you know what we measure every month, if you want us to change something in the at-a-glance and provide different information, that's our report that goes out to all stakeholders, CFAC, providers, it's in the news, it comes to you. We'd be glad to finesse that as well.
Yeah, and the whole point of this, back to where I started, my responsibility for you is to make sure you know this is out there, that we have some degree of discussion about it, and to ask how you want to deal with this in the future. I mean, we could have a quality committee of the board that, really spent time, it's like a lot of other things, it takes some time to really get used to looking at this data and understanding what it means, and kind of growing intelligence around that. Or we could just have it be part of the consent agenda, and then whenever people have questions about it, they could ask. I mean, it kind of gets buried when you do that. And I got sensitive around that one day and said, we better just stop and make sure that we're, just get this all out there and have people be able to react to it. So that's my topic.
Is this same report going to be given to the whole board?
No.
Now, what I just did here, we're presenting it to the executive committee to see what you would like presented to the executive committee in the future and to the whole board. So that, Brian, that was part of your point, right?
I think that's a lot of information. I think it would be good for the whole board to at least have copies.
We can do that.
I totally agree with that. I think also in regards to what we want to prepare maybe in the future to show to either executive committee, if we have one in the certainly grievances, percentage of grievances and things of that nature. We want to know about that. We'd like to know the numbers, the total numbers that we're seeing or talking to or having called to. I'm only speaking for myself. But those types of numbers are what interest me. Now, what you do about it, that can get really lots of numbers out there, and probably I wouldn't understand it if I heard it. But I can understand grievances, and I can understand all this other.
No, but our job is to make it so you can
Yeah.
understand it. I
But
don't
you know what I'm
understand
saying, those are things that we react to more than anything else.
This October data will be in the next board meeting consent agenda. It wasn't submitted to the state or prepared in time to get into this.
It's great information.
Boards. But I did bring it here. But one thing I want to point out about the grievances, so the numbers are important, obviously. But I also think that it's very important to look at how quickly we resolve them. Because
Yes,
that says a lot
that
about.
says a lot,
customer
yes.
service. So,
And I think Ronnie had a good point in finding out those grievances that might go to providers that we don't hear about, or calls that go there that are not even getting on this report.
so what I can do with that is actually take that to our provider advisory council and ask them how they would recommend that we get those numbers, because providers do have quite a burden on them for reporting numbers to us, and we want their input anytime that we ask for them to give us additional information, because it,
You require anything from hospitals, you arrest hospitals to give you the number of people who's waiting in their ER?
that's Jenny's report, and she brings that to the board, and she has a report, I think, is it in the
I've never
board?
saw one.
It's in the consent agenda every month.
See, that's,
So we don't have to read it.
I understand the concern about what those numbers might be with private providers and so forth, but I think that we ask so much of them as it is, and we ask so much of our employees as it is in terms of data collection. I'd rather than spend time working on solutions to problem areas as opposed to trying to collect more private providers. If there are problem areas, we're probably going to hear about it in complaints.
yes,
And
That's the reason I'm.
The other thing that we did, Michael,
That's something really interesting.
that I didn't bring today, we do get what are called incident reports, and those are reports that providers fill out for any kind of episode that is outside the standard of care. So if I were on an outing and I fell and sprained my ankle, and the provider would do an incident report like that, it's outside of what you would expect from your normal routine care. And we can bring that here also. And what we do is we look at those and how providers respond to those, because again, things happen. People fall down, they sprain their ankles, but it's more about how they respond to it, how they make sure that they looked at the safety issues surrounding that, and so we can bring a report like that also.
but we do monitoring of our providers, correct?
Yes, we do.
In other ways.
Yes, we do.
And to me, to ask them to provide all this extra data. So for example, let's say that the providers can tell you how many calls they had coming in on their phones, and they provide it to us and you give it to us. What do we do with it? What does that mean? I can tell you, for example, that I've been on First Foothills and now Smoky since 2002, and I can't tell you when we've had any actionable information related to, oh, so you had that many calls this month. Well, we need to do X. I just think that that's not a burden we need to place on them or our staff. And I think what you're providing is great. In fact, for me, I'm assuming that in some way your computer helps you generate this. Is that correct, or you still manually enter this?
For the most part, well, we manually enter it into the report format, but we get the data from reports that have been
Somebody's
written
still
down.
preparing the
For the
Excel
most part,
database.
some of them are manual measures though still, because of what the source from which we're required to get them.
guess what I was talking about is, so this isn't coming out directly out of the computer, it's not spitting this out, somebody's creating an Excel database, right? To me, to then go and do one of these two, while it looks very nice and it is easier to read, I don't see the need to put staff to the extra trouble.
It doesn't, now that we've done it once, doesn't take anything to do it again, because once you put it in the spreadsheet, you just generate it.
That's true, that's
So-
true.
The reason you want to provide it, like, if we're sending 70 people in our catchment area, they're looking for help. That's the reason you want that
I
information.
should know that based on.
Well,
the
now,
No.
if they're state-funded consumers, then even if I call the provider and ask for services, the provider lets Smokey know through a process of screening, triage, and referral through it.
So you got that information already.
Not for all Medicaid consumers, no. It's not required for
Just wonder how
Medicaid.
many, that's how many people you really seeking help in the area.
We can get, the typical way that's done, you know, I mean, there's different ways we can do that, but the most reliable way of doing it is through paying for something, through paid plans. Sooner or later, it's gonna get to that point. It's either gonna get counted towards payment, or it's gonna get paid directly. And it's usually, that's the place where you
For instance, if you
use
look,
that to count.
if you look
That's
in the,
fine.
under persons served on your Medicaid report and persons served on your state-funded report, then in October, we served a total of unduplicated 8,476 Medicaid consumers and 2,348 state-funded consumers. So if we added those together, those would be the number of individuals that we served. Not necessarily how many services they got, they could have gotten 3
That's
services.
how many come, make a call or walk to the door or done something.
That's how many we paid for services for.
Got
That-
the service.
That's a good one.
I mean, part of the reason I say all that too is, I should have said it earlier, when I made a mistake earlier, but the more we ask the provider to do bean counting for things that we do in other ways, the less time they have to provide services. And to me, that's the bottom line right there. So if we ask them to do more bean counting or something that we may not really need or use, or we already have in some other way, then they're not able to serve somebody that day. That to me is,
I didn't know, I just want to make sure I can walk in clinic, I walk in clinic. But those folks are being, somewhere they're being counted, either by, they're getting paid, or they have to pay for services, or whatever.
We want them to be busy.
But there's a lot of people that are going out the roof, so,
Well,
I mean, everywhere like that, so.
okay.
What we do about that?
It's a big topic. We good?
Yeah, and, just one additional thing, this monthly report, those data points that you saw in the LME MCO, comparison for the Western Regionalization, this is the place that those numbers came from, the August report. So every month we'll have one that has more recent information.
Thank you for your report. Future board and executive committee meeting schedule. Our next meeting is December 19th, is that correct?
It's at the Renaissance Hotel, because this facility is not available.
Okay. And that was, time for the meeting would be 1 o'clock? Is that right?
It will be fine.
So it will be this meeting in the line.
1, 3, and 4:30.
Remember the Renaissance. Anybody who comes here, Jill will come over and pick you up and take you. Responsibility on
For a
her.
small
for a little rich stuff,
She'll
yeah.
have a van.
You walk across the back here.
He really good. It's pretty cool.
Yeah.
Where you got a little, something.
Are they using it?
It's still Renaissance.
Yeah.
All right.
since we only have about 15 minutes, I don't think we have time to go into closed session and talk about the, we can do that.
We can do that at the whole board meeting.
Yeah.
Let's keep it all the same thing.
Is there anything else that needs to come before the executive meeting? If not, we'll come back on meeting.
Good adjourn.
We have a motion, Ed, Dang a second, all in favor, say aye. Aye. Okay. Thank you, everyone.